Minanam Professor Stephen Schensul, of the University of Connecticut School of Medicine, and Principal Investigator on the U.S. side of the Rishta Women's Project. In conjunction with the Institute for Community Research and Tulane University in the U.S., and with a number of organizations in India that have included the International Center for Research on Women, Population Council, the Tata Institute for Social Sciences, the National Institute of Medical Statistics, and the Topiwala National Medical College. We have worked together for a decade in urban poor communities in Mumbai, and looking at a whole range of issues that have included sexual and emotional risk of both men and women. Our current women's project focuses on the sexual and emotional health of married women. Much of their risk comes from their husbands, but despite the importance of the husband-wife relationship, this rarely has been considered in looking at sexual and emotional risk. And this Rishta project has sought to address that both from the point of view of research to understand that relationship, as well as intervention to improve the relationship and thereby improve sexual and emotional health. So our key questions for the project involve, first, what ways does the husband-wife relationship affect sexual and emotional health issues of married women? Secondly, for those women who have difficult marital relationships, much of the way they express those difficulties and other negative life situations is through physical symptoms. And those physical symptoms are brought to primary care, both in the private sector as well as the public sector. The question is, can we integrate interventions into the primary care setting? Thirdly, can counseling of individual women, as well as group couples intervention, in which both husbands and wives would participate, can that be effective in impacting on sexual and emotional health? And finally, can this work be enhanced in the context of community intervention and education, in which we would work with various sectors of our study community? This project is occurring at an extremely important time in India, in which there are a number of new national policy initiatives that include the National Urban Health Mission as a part of the National Health Mission, seeking to improve the quality of care for urban dwellers, particularly those in slum communities. A second policy initiative is the Mental Health Act, geared to address a broader range of mental health and emotional issues and provide services for those issues. A third policy is the desire by the Indian government to decentralize HIV prevention and treatment services throughout the national ministries. And finally, there's been a considerable emphasis on looking at women's equity and equality and the reduction of violence towards women. The Rishta Project has taken these initiatives and developed what amounts to a demonstration of whether we can integrate primary care, emotional, sexual health, marital relationships, and other aspects in a local community. And as a result, is a demonstration project for these key national principles, national policies. We have key principles of how we function. The first of these is, in this project, the first of these is a concern with the cultural context. How the structure and community dynamics provides a unique perspective that we can take in terms of understanding the situation as well as building the intervention. In this particular case, much of women's complaints that they bring to primary care settings is describable as safed pani, or vaginal discharge. This is of considerable concern to women, and yet we found that it's not predictive of physiological disease, but rather of negative life situations and difficult marital relationships, violence, disempowerment that are characteristic of women who are bringing safed pani into primary care. Our second principle is the need for focusing holistically on multiple factors in the structure of the community, in the nature of the marital relationship, and various aspects of women's lives. Even as we attempt to focus on one or two issues, usually this is a product of multifactorial causal factors. The third area is multi-level. It's not good enough to work with individual women or even couples, but to work on both systems and structural change as well as community intervention. The fourth principle is a concept not so much of sexual risk but of positive sexual health. This is a concept that has been advanced over the last decade by WHO. And this concept encourages a perspective that looks at a whole range of issues, including sexual knowledge, sexual enjoyment, as well as risk. And finally, we've utilized the narrative intervention model, a therapeutic and approach that focuses on holistic care, consistent with Indian systems of medicine, in which a number of issues are explored both individually, in group, couples, and at the community level. Our methods for doing our work have included formative research to build that understanding of the cultural context, intervention, which has included our work at the community level with partnering with non-governmental organizations, as well as the large Muslim sector that characterizes this particular study community. This has been a particularly productive approach and has allowed us to reach and make changes in the perspectives of men about women's equality. At the healthcare system level, we've organized a women's health clinic within the municipal urban health center, and this women's clinic has been a key factor in creating a set of services amenable to women's issues, involving both internal exam and appropriate STI testing, and has been an innovation that now continues after the project will be finished. And finally, we've done both group couples intervention that's consisted of 6 sessions in which various topics related to the marital relationship and sexual risk have been discussed first in single gender, and then among couples themselves, and finally 3 to 5 sessions for women selected for individual counseling. Our evaluation has involved a gender-based scale, the gender equity scale, which we've given to at the community level for 3 years, 2009, 2010, and 2011, and monitored the change in attitudes toward gender equity both in the study community and in the control community, as well as among the NGO staff and the imams. A baseline medical exam for all women recruited into the project, and a randomized controlled trial to test the relative efficacy of individual counseling and couples intervention. This has been an exciting project, one that has developed close personal relationships among the collaborators, has bridged and allowed us to share our special expertise, both on the U.S. and India side. We look forward to productive relationships in the future as we continue our projects, and as well as disseminating these results in the communities and at the national level. Thank you.